ऐसे मैं देखती नहीं ना हूँ कुछ वेबिनार में से पढ़ लेती हूँ तो।
So it's live now. It's live now. I will start screen sharing and we start the program. Namaskar. Welcome to this 32nd episode of Searchlight webinar. This time the Searchlight is on updates on I would like to introduce my convener, Dr. Purvi Agrawal, who is an executive member of SFM Raipur and a very, very active help to me. She is the director and consultant at Krishna Fetal Medicine Center, executive member of SFM, past IFS executive member, IOTA and FMF certified, and trained in fetal procedures, many national and international publications, and is a training faculty for fetal ultrasound at SMSA Hospital. So welcome, Purvi. Over to you.
Thank you so much, ma'am. A very good evening on this rainy day. I would take this opportunity to welcome everyone to Searchlight number 32. That is the 32nd Wednesday for Enlightenment. With immense pleasure, I welcome all of you. And I would want to tell that this Searchlight would be the one of the dearest Searchlight to me, as my mentor, my guru, Dr. Adi sir, is the eminent speaker for today. Without any further delay, I would like to introduce Dr. Asha Jain, ma'am. Ma'am is a director of SMSA Hospital. She is she has been a zonal chair, Foxy Food and Drug MSc Committee West Zone. She is executive member of ISCCP, CG ISAR and CG SFM. Past, ma'am has been president of ROGS. Ma'am also would want to ask for vote for next Foxy Food and Drug Administration. Very warm welcome, ma'am. Over to you, ma'am.
Thank you, Purvi. So we start any program with blessings of the divine. So I request everyone to please join in prayer and then we start the inaugural session. Shri Ganeshaya Namah. Now I would like to take the program a little in reverse, as Dr. Ashwath Kumar sir has to leave for another webinar immediately, and he has been kind enough to say yes to me to come as a guest. So we all know, sir, he was the past vice president of Foxy in 2019. He had a very great Gurukul program for students and loves teaching. He's also a teacher, ICOG Governing Council member 21-23, IAG Managing Committee member, Foxy Quiz Committee Chairperson in the past, VP KFOG 2017, past Secretary General KFOG, has a publication exploring new horizons in obstetrics and gynecology, and many, many more. He also runs a YouTube channel specially for students. So I'm very honored to have you here, sir, and requesting for your words of wisdom.
Thank you, madam. First of all, I thank Asha Jain, madam, for inviting me for this webinar as a guest of honor. And I thank, very proud to be with K Shah sir, who is my mentor in Foxy. Sir is the person who brought me into Foxy and encouraged me to. I still remember under Sir's presidentship, I was the first time I entered as the quiz committee chairperson. After this, I was lucky enough to become the vice president of Foxy. So proud to sit with Sir, at least online, and seeing Sir after a long time. Thank you, sir, and proud to be with Yashodhara Madam and Mohit Shah, sir, and for the guest of honor. Then thank you, everybody. And today's topic is very interesting, actually. Placenta. Even if we say we discuss so much about medical disorders and all these things, medical disorders, many times GDM, PIH. Finally, we come to it that the pathology comes in the placenta. So many things to learn in placenta. It will be very useful for not only for the consultants, it will be very useful for the postgraduates also. I shared it among my postgraduates, seeing that they were very happy to see placental physiology as well as the placenta as ultrasound features of ultrasound. In ultrasound, placenta is so important. Whatever condition you take, for example, classically example twins, the placentation is the most important feature that determines the prognosis of the baby. So I'm not going deep into because you are all waiting for the speakers to listen from speakers. Once more, say thanks, and I wish Asha Jain Madam all the best for her election and hope that she wins and becomes the chairperson. So I'm very happy to be with Belgavi, Tuli, Sangvi, Great Pune, Greater Pune, Harda, Latur, Magadh, Raipur, Salem societies and members of the societies. So proud to, at least through the webinar, I could reach you all. Thank you so much once again, madam. Thank you and all the best for your election as well as this program of Searchlight. Thank you.
Thank you, sir. Thank you so much for sparing the time to be here. We are really honored and happy to be.
Hello. Hello.
Okay.
Yes, Yashodhara ma'am. Ma'am.
Hello.
Yes, ma'am. We can hear you. Yashodhara ma'am, we can hear you. So, Ashwath sir, you may. Thank you for being here. And if you are here for some more time, we'll be happy. But otherwise,
I would have be allowed to be here, but I have to go to the ICOG webinar now itself at 5:15. The ICOG is going on. That is why. So thank you so much. Thank you.
Thank you, sir. Thank you so much.
Thank you.
Now, I would like to welcome and say a lot of thanks for accepting to Mohit Shah, sir, who's the National President of Society of Fetal Medicine, National President of Musculoskeletal Ultrasound Society, VP Indian Federation of Ultrasound in Medicine and Biology, Consultant Fetal Medicine, Surya Mother and Child Care Hospital, Santa Cruz, PG Diploma in Musculoskeletal Ultrasound from University of Murcia, Spain, and Organizing Secretary of FETOCON 2018, 19, and 22. He is also a very, very great speaker and very, very knowledgeable about fetal medicine. So I welcome you, sir, to say your words of wisdom.
Thank you once again, Dr. Asha, for inviting me and sharing the dais with Dr. K Shah, Dr. Ashwath, Yashodhara ma'am. Dr. PK and we have been constantly now meeting of late, also because of IFMB, but it's always good to share the stage with such a stalwart. And the talk that you've chosen, I like the talk simply because when we talk about fetal medicine, we're always talking about the fetus. Placenta is often the most neglected organ when it comes to teaching or when it comes to evaluation. So I believe that a placental evaluation by none other than Adinarayan is a perfect setting for today's webinar, simply because Dr. Ashwath has already covered that, but we do understand that not only is it a barrier to disease, but it is also a reservoir and a main nutrient between the mother and the fetus. So everything that we think of the fetus or can affect the fetus is probably placental mediation. And when we talk about fetal growth restriction, we've discussed that in detail that the placenta plays a major determinant as to how fast and what would be the stage of insufficiency. Similarly, placenta can also get adherent, which if is missed can lead to catastrophic consequences for the obstetrician as well as for the patient. So I believe this is a perfect setting with placenta being covered by Adinarayan. So I wish you all the best and I'm eagerly waiting to listen to the rest of it. Thank you so much.
Thank you so much, sir, for those words of blessings and good wishes. Now, I would like to introduce Dr. Yashodhara Pradeep ma'am, who was the VP Policy 2022-23, Professor and HOD, Dr. RML IMS Lucknow. Previously, she was Senior Professor at KGMU, Professor ELMCH Lucknow, Chief Editor JMH IMS, has more than 35 years of experience, a very humble, very knowledgeable person, now agreed to be with us this evening. So welcome, Yashodhara ma'am. We are eager to have you with us.
Thank you, Dr. Asha. First of all, I would like to say all the best to you for your elections. You are such a senior and humble person and such a knowledgeable person. You are a truly academician. And I really appreciate that you have organized 32 Searchlight program this time. And you have, so many societies are today joining. That's a President and Secretaries of Deoli is Savangi, Dr. Megha Karnik. She's the Secretary of the Deoli Savangi Society. From Belgavi, Dr. Manju Hooker. He's from GN Medical College, Belgavi. From Greater Pune, Dr. Varun Ashok, who is a Secretary of Society of Fetal Medicine. From Latur, Dr. Suvarna and Dr. Pratibha Sanjay Patil. And Dr. Divya from Dr. Tabassum from none other than your Raipur. She's the president there. And from Salem, Dr. Ashwani Rao and Dr. Vinayak Mishra. From Vinaya Maiskar. He is also from Raipur. And as Dr. Mohit Shah said, that he's the speaker, Dr. Adinarayan, is a president SFM and very well-known person. You are all looking forward for Placenta. My regards to Dr. K Shah, who are my senior, and we are all together all the time. So Placenta, as we all know, that it is such an important thing that nobody can ignore it. So it is always welcome to listen about the placenta. Thank you so much, Asha, for giving me the opportunity.
Thank you so much, ma'am. Your video was not on, but thank you so much for those words.
Oh,
now,
my video was not on?
No, ma'am. Now we take great pleasure in introducing K Shah, sir. He is Professor, Department of Obstetrics and Gynae, LTM Medical College and LTMG Hospital, Sion, Seth GS Medical College and KIM Hospital, Parel. He was past president of FOXY, IAG, IFUMB, MOGS, and AFTT, past dean, Indian College of Medical Ultrasound, past chairman. So he has, you name it and he has it. But one wrong thing that he has received is the Lifetime Achievement Award, which was received in 24, because I think sir has still a lot of work to do. So welcome, sir. Welcome.
Thank you very much, Asha, for your kind words. First of all, congratulations on this webinar, that is Searchlight 32. And it's so nice to see so many societies of our country involved in this particular webinar. And what is amazing is that the whole webinar is on placenta. As obstetricians with busy practice, when you do ultrasound, you hardly give any attention to placenta. But nowadays, with so many cases of placenta accreta spectrum and fetal growth restriction, I think placenta has gained tremendous importance in our practice. And you can't afford to neglect placenta. So it's very important that you picked up this particular topic, because I have not heard of placenta being talked about in webinars, and you have given full webinar to this placenta. I'm very happy to see that Dr. Ashwath and Dr. Mohit Shah have already talked about the importance of placenta, so I won't repeat it. But it's so nice to see that Dr. Adinarayan is going to talk on placenta for 45 minutes. I'm very eager to hear, because he is a president of Karnataka SFM. And it's so nice to hear someone talk on placenta for such a long period. So all of us are waiting for this, and I hope more and more crowd joins, the more and more people join us today, because this is something which you will not be hearing too often. Not only that, but Dr. Asha is going to moderate the panel discussion on placental physiology relevant to an obstetrician. And there are very distinguished panelists. I won't name now because of time is short. So thank you very much, Asha, for involving me. And it's nice to share this platform with three nice people whom I know personally well, Dr. Yashodhara Pradeep, Dr. Ashwath Kumar, and Dr. Mohit Shah, who are all three are guests of honor. Asha, all the very best for your chairmanship that you're contesting for in Foxy for the year 2024 election for Food, Drug, and Medical Surgical Equipment Committee. So all the very best from the inner core of my heart, and I wish you success for the same. Thank you, and wish you many more such important webinars.
Thank you so much, sir. It's such a blessing to have you with us all the time. You know, I don't think you remember, but my Searchlight 1, you were my guest.
Oh.
So I started with you, and I thought that it's been quite a few months, so now I should take you again. And this is a topic I knew you would be interested.
Thank you.
And when I was thinking whom to ask to speak on the placenta, me and Purvi, we kept thinking, and Adi sir very kindly accepted, because I know he is one person who can speak in such a way that every difficult subject seems easy. So thank you so much, Adi sir, for accepting this invitation. I'm really very, very grateful. And now I would like to share the screen and invite the chairpersons so that we can start the academic session proper. Over to you, Purvi.
Thank you, ma'am.
Contraceptive clinic also in
So
case
for the session
just
one,
to
I would like to invite Dr. Manju Sinha ma'am as the first
methods of the
chairperson,
contraception for
ma'am
the
as
first
president MOGS
for
Gaya,
the okay.
consultant Nisha
Yeah,
Clinic,
no, we're done with the
Road,
lines.
Patil
And
Road, Gaya,
you
lifetime
know,
member of
sir,
Fox IMA.
Would you mind repeating it? There was a lot of disturbance.
Yes, ma'am. I would like to invite Dr. Manju Sinha ma'am. She is President MOGS Gaya, Consultant Nisha Clinic, Katari Hill Road, Gaya, and lifetime member of Foxy and IMA. I would next like to invite Dr. Pratibha Patil ma'am. She is Professor Obgyn Consultant Sidhweshwar Clinic. She has an academic experience of teaching undergraduates and postgraduates for the past 20 years. She has many national and international publications, many paper presentations and publications. She is faculty at AICOG Bhubaneswar. She is President LOGS 2425.
LOGS is Latur Obstetric Gynac Society.
Yes. Next, I would like to invite our own Dr. Tabassum Dalla Madam. Madam is President Raipur Obstetric Gynac Society, Vice President IMA Raipur. She has diploma in minimal access surgery, RT. She is consultant Obs and Gynae at Jabesta Hospital. She has been organizing chairperson for many events in Raipur, Chhattisgarh. Ma'am has received various awards, including TOBIP Award by JCI, Women Empowerment Award, Nari Shakti Award. I would now want to ask one of the chairpersons to introduce our eminent speaker, Dr. Adi, sir.
Hello,
Requesting-
Purvi.
Yes, ma'am. Please go ahead.
Dr. Adinarayan Makam. He is the director founder Adi's Advanced Institute of Fetal Care, Bangalore. Director founder of UTU Group. Trained hundreds of postgraduates and postdoctoral fellowship in fetal medicine. SFM Karnataka President 22 till present. Multiple international and national publications, researches, audit posters, invited faculty at many national and international forums. Gold medalist, RUGHS. Now we'll request Dr. Makam to talk on the subject placenta.
Sir's tagline is understanding the unborn. I'm really very honored to have you, Adi, sir. Please, over
Thank
to
you. Okay. Thank you very much for all those kind words, madam. Am I audible?
Yes, sir.
Okay, good. Can I share my...
Yes, sir. Yes, sir. One thing, sir, I would like to say, all the Society of Fetal Medicine consultants who have helped me in these webinars, whether it is Mohit Shah, sir, Aparna, Khurana, sir, Praveen, sir, excellent speakers.
Wonderful, madam. I actually didn't know about this program. I wish I knew. I would have joined for a lot of them. And now I've told all my fellows to join. So if I can get the link every week, whenever you do, I'll ask them to join. And I'll also join.
I can, if I may intervene, I can vouch for Dr. Adi's excellence, not only in the content, but also the way he presents it. So it is going to be a treat to each and every one of us to listen to him.
A lot of pressure. I hope I live up to your expectations. Thank you.
Sir, this is the first time I'm seeing you sitting and presenting. I've always seen you walking on stage.
Correct, madam. I would like to stand up and present. It's nice to see the audience. This is a little bit not comfortable for me because I need to see the audience. That's okay. Nice. Okay. How much time do I have, madam? About 45 minutes?
Yes, sir.
Okay, fine. I was thinking placenta throughout pregnancy in 45 minutes is almost impossible. People have studied placenta for years and still they have not understood. And if I have to present whole placenta in all three trimesters, including normal and abnormal, I may not be doing justice. So I will not give you all that is there with placenta, but I will brief you and I will give you some overview of the placenta in the next 40-45 minutes. If it is going too much, you can stop me anytime.
No, sir. Actually, our audience is mostly obstetricians and gynecologists. So they need to understand relevance. For them, 45 minutes is enough. For a fetal medicine person, it's not enough.
Fair enough, madam. Fair enough. Okay. Maybe obstetricians know more about placenta than us. I'm also an obstetrician. Anyway, so I'm retired obstetrician now. Okay, good. Thank you very much for all the kind words. And let's see. As Mohit sir said, that placenta is often neglected. So we only worry about beautiful baby like current Dopplers and we ignore looking at placenta. So this is a right time or right juncture looking at placenta, whether it makes a difference or not. Let us see. I have plenty of cases and I will take you through. What an interesting organ. What an amazing it is. We should pray placenta as goddesses. Annapurna, it will provide your food, nutrition, oxygen, and so many functions it does. But because looking at baby, we forget placenta. So whenever I think placenta, three eyes. One, very interesting organ, but often ignored because we have not understood placenta completely. However much we do, there is a lot to be discovered by placenta. So just the beginning. So the premise is if you look at the placenta and somehow assess the appearance, function, and do some test, then it will tell me whether the baby will grow or is it growing or should we deliver the baby. On all this information we can get by looking at placenta or studying the placenta. So the obvious benefit of looking at placenta and studying the placenta is to make the perinatal outcome to the optimum level, both for the fetus and for the mother, and also for the obstetrician also. So now, in my talk, I've divided into three major categories. One, its appearance, called sonomorphology of placenta. Next, how do we assess the function of the placenta briefly? And if it is abnormal, how are we going to deal with it? I may not be able to deal with all the abnormalities in much detail, but I'll give you the overview and we may take questions in the discussion. Now, should we look at the placenta at all? Because we did in the past where we didn't have Dopplers or biochemistry, only way to assess the environment of the fetus is to look at the placenta, make some judgments. That's why we did a lot of grading, grading, looking at the calcification and appearance, and made a lot of grading. But it did not actually translate into clinical benefit. So we stopped, and I actually don't know how to grade. I'm not young, but even in my time, we used to do that. That's completely out of the equation now because it doesn't tell us. So before actually look at the ultrasound placenta, just going back a little bit to look at the placenta diagrammatically, you can see, I don't need to go through all the details, but few important points. This is the, can you see my cursor on the screen? I hope it is, and if it is not, let me know. So this is a chorionic.
Let's see the cursor. We can see cursor.
Lovely, thank you. So this is umbilical vein, and the fetal surface is a chorionic plate, and the maternal surface is basal plate, and in between you have villus space, intervillus space. In the intervillus space, mother brings the blood and pours into this intervillus space. The fetus gets the blood through the veins into the umbilical vein, and fetus gets the nutrition and all the necessary nutrients, and the metabolite will come out through the umbilical arteries, and the exchange would happen here. So to understand the embryology, anatomy, physiology, and a little bit of biochemistry, I found a nice video. It is not copyrighted. That's why I downloaded the video and I'm going to present. It's about 3 minutes. I want all of you to see this one. It's one of the beautiful animated clip. So much thanks to the Bethisa group of animations. I'll play that video now.
Development of the placenta begins during implantation.
Okay, I will illustrate in my words. Okay? The morula invades the endometrium, and it have a cytotrophoblast, and cytotrophoblast becomes syncytiotrophoblast, and syncytiotrophoblast try and burrow the endometrial glands, endometrium, endometrial stroma, and by proteolytic enzymes, obviously, where there are beautiful nourishing arteries and veins are there. And once it settles inside the endometrium, the outer layer of the morula will develop some lacunae, and these lacunae unite and become bigger, and it erodes into the arteries. So that's how it starts to get hemocroidal blood supply to the developing embryo until the fetus has its own arteries and vessels, arteries and veins. This network of arteries will help. So if you look at I'll pause this one. If you look at, this is the endometrium, and this is the developing embryo, and this is an extra embryonic mesoderm, and the outer layer is a cytotrophoblast. So, and the syncytiotropoblast buried into the endometrial decidua, and the cytotrophoblast makes its way, paves its way. This is called primary villi, and then the mesoderm goes into the villi, so secondary villi, and finally the blood vessels, developing embryo develops the angiogenic tissues, and that forms the blood vessels, and those go inside. With this is a tertiary villi. So this tertiary villi is ready to get its nutrition as a parasite. This is the lovely decidual structure. You have some of the villi are anchoring. So this is to keep the villi in place, and others are branching. These are a functioning one. These are the supporting pillars. And this is the environment of the decidua, where the mother will provide nutrition into that villus space, and the developing umbilical cord with arteries and vein will drain the blood from the fetus in the arteries and goes into the intervillus space, where a lot of exchange of the nutrition and chemicals and oxygen and so many functions it performs. And through the endometrial veins, the blood drains back into the mother, and through the umbilical vein, the blood comes to the fetus. So what a beautiful design. Amazing. Of course, the nature is the best, and nature has taken a lot of several millions of years to design this one, but I don't think any one of us yet can reproduce this organ. And mind-blowing. The more and more you study, one second. So more and more you study, the more and more print it. Okay. So lovely. So with that small video, we will see how does the placenta looks. The placenta, all of you know in the ultrasound, it is a homogeneous structure, elongated, length more than the depth, and usually the umbilical cord attached at the center, and the placental vasculature is full of blood vessels. And looking at the stroma and looking at the vasculature, we may glean some information regarding how this baby, how the fetus may develop, or can we predict development of any preeclampsia or growth restriction. So if for a nice normal placenta, it should be located in the upper segment, not in the lower segment, and it should have a homogeneous structure. It should not contain any sonolucent areas. If you contain sonolucent areas, obviously these structures are not participating in the gaseous exchange. So obviously, if you have multiple sonolucent areas, whether they can be placental lacunae or placental lakes, which takes away the functional space. Hence, you may expect growth restriction or development of preeclampsia. I will go through the cases and illustrate how this might help, or it might not help, or do we need to do more, or should we take so many things into account rather than just looking at placenta? I will tell you with my cases. Okay. So briefly, if you want to look at the function, if the baby is growing well, that means the placenta is working well. That is an indirect way. So is there any way we can look at objectively and make a decision about the placental function? Is before actually going to assess the function. So do you think placenta works as a cardiovascular system? Of course, Does it work as a respiratory system? Yes. Would it work like a GI system? Certainly. Would it work like a excretory system? Of course. Also works as an endocrine system, produces a lot of hormones. And also acts as a protecting, not just the physical, it also produces a lot of immunoglobulins and immune-mediated cells to prevent the diseases in the fetus. It's an amazing organ with lots of this functions. How do we assess? How does it work? And is it justifiable not assessing the placental function at all? We worry only about baby, of course. So if the baby is not good, then you go and look at everything. Is there any way we can look at the placenta and predict what happens? We have evolved over a period of time, and especially the Dopplers have given us a lot of information, although it is not mathematics, but looking at the Dopplers, indirectly we can assess the placental function. We can also take some blood and look at the chemicals and the chemical compositions, chemical concentrations, and indirectly we can say whether the placenta is working or not. Now, I don't want to go much into detail about Dopplers. It may take another class on itself, but here I want to make 2 or 3 points. Placenta is an interface between the mother and the fetus. So if you interrogate the uterine artery, we will know about the placental side, maternal side of the placenta. And if you interrogate umbilical arteries, it will tell me about the fetal side of the placenta. And how do we know? As all of us have understood, the trophoblast will go and destroy the tunica media, the muscle of the arteries, and make them, instead of resisting arteries, very capacitant, easily distendable. One second. Also check. You've given all the options. But sorry, this was she was waiting for a longer time. So the thick arteries, resistant arteries, become very pliable, easily distensible blood vessels by the trophoblastic cells. And if the placenta has formed properly, and if these trophoblasts have destroyed the muscle layer, the volume of the blood vessels in the placental stroma is so much so that if you look at the specimen, this is a Stuart Campbell's work, where they took the well-grown baby and the placenta, the stroma is destroyed by acid, and they have introduced a cast, vascular cast, so that the acid has not destroyed the cast. So almost 70%, 80% of the volume of the placenta is by your blood vessels, because there are so many and they're so dilated vascular structures. Most of the placental volume is made by the vasculature. And if you take the growth restricted fetus and if you do the same exercise, not many blood vessels. Obviously, this placenta is offering a lot of resistance, and white loss of resistance, the presentation is not beautiful, smooth, and spongy. The blood going through this placenta, either from the mother or from the fetus, is very difficult. That means there is not much of gaseous exchange, nutritional exchange, extramural exchange. Obviously, the placenta works like 4, 5 different organs, and all these organs are at a risk, and if they are not working properly, obviously the fetal outcome is not so good. So now, how do we know this is postnatal? We can't wait until the baby is delivered and do all this exercise. So can we know anything before? Yes. What we can do? We can do Dopplers. Why do we do Dopplers and how do we Dopplers? Maybe some other day we'll take it. We can assess the velocities in systole and diastole, and we can do some mathematical calculations, and indirectly we will know whether the placenta is offering any resistance or not. In the first trimester, you do at the level of internal loss. In the second trimester, you do at the iliac vessels, and you do on both sides and take the mean. And in the first trimester, 2.3, if you don't have the nomogram, 2.3 is a cutoff, and in the second trimester, 1.4 is a cutoff. Would you do it in the third trimester? Of course, you do it in a third trimester also in a growth restricted fetus. If the baby is growing normally, you may not want to do the uterine artery Dopplers in the third trimester. Okay. One point for all the gynecologists, because most of the fetal medicine specialists have gone through this phase, and obstetricians may or may not. I will illustrate a case of uterine artery notch. I want you to watch this one, and the notch becomes more prominent, becomes less prominent as I change the PRF. That's the uterine artery. You take a gate. How the uterine artery notch is so deep. So if I reduce the PRF and increase the height of the waveform, the notching becomes very prominent. And if I reduce the height of the waveform, the notching is not so prominent. So by looking at the notching alone, you should not make any reasonable management plans, because in PI, pulsatility index, we take the whole cardiac cycle into account, and we have the mean calculated. Mean velocities are calculated. So even if there is a notch, it will give me information about the notch in PI. So instead of making a visual impression and making a management decision, it is much better doing a PI and taking a 95th centile as a cutoff, and making a decision is much better than looking at the notch. So of course, notch is important, but not only notch, you need to look at the PI. As I illustrated, sometimes it looks so deep and sometimes it is very subtle. So we should not depend upon the subjective. That's what I wanted to reiterate. And that is about the maternal side. What about the fetal side? The umbilical artery coming from the fetus, going into the placenta, will tell me whether the placenta is offering resistance, whether there is enough resistance, or is it acting like a smooth receiving cotton ball where the blood can flow easily. If it becomes like a brick, like the one which I showed you, then the blood going into that organ can be very, very difficult. That's why your velocities comes down. And during systole, anyway, the heart pumps the blood, it goes forward. But in diastole, there is not enough force to go through this organ. You will have reduced diastolic flow. So if you look at the disease process, in the beginning, if there is placenta working very well, you have both systolic and diastolic flows, nice and beautiful. But if the placenta is offering resistance, what will happen? Systole, the blood will go, but diastole keeps coming. And if the disease process is too much, you will have absent diastole. And once it becomes like a brick and 70% gone, you will get a reversal of the flow. So one more important point I want to make, and then I'll go to other. So one important point is, until about 30% of the placenta is gone or malfunctioning, your umbilical artery will be completely normal. So looking at the umbilical artery Doppler, you cannot say that placenta is doing very well. It may be 25% gone. Yeah, only after 30% of placenta is gone, approximately, you will have ambulatory changes. Okay. By the time you see the absent diastolic flow in the umbilical artery, 50% of the placenta is gone. And if you see reversal of flow That means 70% of the placenta is gone. So we need to understand. We cannot look at the placenta and see how much it is working. Indirectly, what is telling us is your Doppler findings. If the Doppler is completely normal, placenta is normal, but it is less than 30% damaged. If the umbilical artery becomes abnormal, the absent diastolic flow, 50% of the placenta is gone. If the umbilical artery shows reversal of flow, then 70% of the placenta is gone. So until when you have less than 30% damage, babies have an amazing mechanism, and the carotid bodies and aortic bodies would do a pulse oximeter, like measurement of the oxygen saturation. And before umbilical artery shows any changes, the MC can show changes. So this is the reason why you cannot restrict your Doppler studies to only umbilical arteries. You still have to look at MCA. Okay, so biochemistry, it is the lecture on its own. It may take at least an hour to complete the biochemical assessment of the placental function. Briefly, there are several molecules we looked at, chemicals we looked at. Only about 4 stood test of time. One is your beta HCG, another is PAPE, PLGF, and S-split and PLGF. Okay. Don't have much time to go through in detail, but what is important, if the beta HCG is very high or if the PAPE is very low, you have aneuploidy risk. In addition to aneuploidy risk, you may have a risk of fetal growth restriction, intrauterine fetal demise, and development of preeclampsia. In the armamentarium, PLGF is a recent one, not very recent one, about 10 years we studied. There's placental-like growth factor. As the name says, if you have enough PLGF, that means placenta is working well. If it is less, it is either aneuploidy or development of preeclampsia. Later on in the pregnancy, you can look at S-split and PLGF ratio. It will predict, or it has got a high negative predictive value to tell you that if the ratio is normal, unlikely that woman develops a preeclampsia in the next 3 to 4 weeks. That's amazing information. Unfortunately, the cost is high, and I particularly don't have any experience because after coming to India, I've stopped obstetric practice. So if anybody has got experience, I would like to listen to their experience. So these are the few chemicals we can look at and indirectly assess how the placenta is working. So if placenta looks and works very well, we have the best perinatal outcome. I think it is not debatable. It is given. So we should assess the placenta. How do we assess the placenta? There is some amount of information you get by biochemistry. Most of the information nowadays is by Doppler, and renowned interest in looking at the placenta. In the last few years, we started looking at placenta again. In the past, we looked intensely, and after the Doppler came, we gave a blind eye to the placenta. And now we started, once we're satisfied with all these things, we are going back again and seeing placenta and see whether it makes any valid management decisions and prediction. We'll see. That's some morphology. So as I said earlier, I don't need to repeat it, the nice, beautiful placenta, long, thin, not thick, and centrally attached placenta, and the vasculature, all these things you should see. It should not be in the lower segment, it should be in the upper segment. Upper segment, it should not have any lacunae, should be uniformly echogenic. If lacunae are there, that is a little bit of a problem. So obviously, the premise is if the placenta looks normal, then you expect that it is working normal, and in result, the baby should be growing very well. So that is a premise. So is it so? We'll see in our cases. So when I wanted to present this one, the one thing it came to my head is placenta is like Ardhanarishwara. Why? Shiva, destructive. The placenta may look like a ferocious organ, but Nandi gives you a lot of peace. So it may not be affecting the fetus. On the other hand, Parvati is a provider, protector, but looking completely normal, but it may be ferocious. It may not be nicer. So looking at Ardhana ratio, you won't say whether it is a nice outcome or a bad outcome. So let me show you in some cases, and I will make my case at the end. So this is a 36 weeker, I think, recently. Look at the placenta. Placenta is gritty, almost solid, and it has got the calcifications, both the chorionic plate and basal plate, and in the placental septae. So it looks horrific. So you would expect this placenta may not be working very well. So that is the appearance. So how do we know? This is a VCIA. So VCIA is a wonderful tool to use, and especially for demonstration, it looks nicer. And if you look at this one, look, the cotyledons you can see, and most of the cotyledons and periphery of the cotyledons, all of them look highly calcified. So you expect this placenta not working, but you look at the biometry. The biometry, actually the baby is bigger. Her abdominal circumference is above 99 centimeters, surprising. And the cute little one, not little one, cute big one. So this baby has got cheeks of my size. So this baby is macrosomic. So the placenta looks so horrible, but the baby is lovely. You can see the estimated fetal weight is 3.5 kilos, above 95th centile. You may wonder with this one, maybe the Dopplers may be abnormal. But if you look at the uterine arteries on both sides, is so lovely. The diastolic flow is so much, it was a surprise for me. And then I looked at the fetal surface, fetal side, both umbilical artery and MCA were normal. So now, looking at placenta alone, we will not be able to tell whether this placenta is working or not. Obviously, we need to look at several things into account and make a decision. So one case where the placenta looked horrible, but functioning very well. Look at this another case. She's actually a gynecologist herself. I've been monitoring her for a longer time now. So at 30 weeks, look at the placenta. Lovely, long, depth is less, not too thick, and beautifully homogeneous appearance. You can see some amount of calcification, but not too worrisome. So you would expect this placenta to be working very well. When you look at the VCI, so I could see a little bit of more calcification than the grayscale, but that's subjective. Look at the uterine arteries, IPI, and both sides. See the 30 weeker, 31 weeker. You look at the umbilical artery PI is very high, and MCA is okay. And the biometry is less than first centile. At 30 weeks, the weight of the baby is around 1 kilo, and estimated fetal weight is less than 1%. And if you look at the chart, and it is way below the lower limit of normal. So what was the lovely looking placenta, but baby is nutritionally deprived, and the blood Dopplers also at borderline. So this is another placenta. Have a look at this one. If you look at this unit as a placenta, a lot of blood is going, and this is a space occupying lesion, not utilized for your nutritional exchange or gaseous exchange. So this is not a good placenta. Whether is it so or not, we will have a look. Look at the Dopplers. Uterine artery Dopplers are completely normal. On the fetal side, although it is 21 weeks, we did a Dopplers, it looks normal. But the biometry is not good. So 3 weeks growth line, extremely small baby. So this placenta looked normal, looked abnormal, and the growth is abnormal. Yeah, Dopplers, of course, normal, may become abnormal later. So this is another fetus. If you look at the placenta, it is not uniformly echogenic. It has got lot of hypoechoic lesions. These are the possible fibrin deposits in the intervillar space. And as I said earlier, the functioning unit is occupied by useless or non-gaseous exchange, nutritional exchange units. So hence, this placenta must not be working very well. Sometimes looking at the blood vessels, there is no objective evidence. There is no objective studies because it's very difficult to look at the studies. So I am a little mental. So I want to look at the blood vessels and see whether the vasculature, because nowadays the slow flow we can okay, they must have forgotten to mute themselves. Okay, lovely looking blood vasculature. So although the placenta appears abnormal, your vasculature is normal. So is it so? We'll see in the uterine artery Doppler, the surrogate marker of the function. The uterine arteries were normal. Growth is beautiful. So this placenta, although looked a little bit abnormal, but functioning very well. So this is another placenta. Again, looks so much of hypoechoic area, although they are not sonolocent. Some small legs, and if you see the legs, and there is a peripheral halo. Also, you can see those are the calcified units. That means it is not working. It is not participating in a business of the fetus. So you should expect a problem here. So you see the uterine arteries looks normal. Growth is less than first centile estimated fetal weight. So and you look at the fetal, there is absent diastolic flow. So the placenta looked abnormal, not that abnormal to expect to see the abnormality in the both uterine artery and umbilical artery. And this fetus has got a deep A waves in the ductus venosus. The baby is in deep trouble. This was not given by the grayscale examination. But if you did look at the VCI, then you can see a lot of calcifications. So may or may not be useful. Of course, Dopplers gives you a lot of other information. So you would make a decision based on the Dopplers, not from the appearance. So this is another fetus. Ill-looking placenta, and you have the placental cyst and placental tumor-like, totally avascular. It was avascular growth, and this placenta is not looking well. So the growth is small, but what is important? All the long bones are smaller here. So now we terminated this baby because the length, all four limb lengths, long bone lengths were extremely small. So this was an abnormal fetus. So the point here is an abnormal fetus may have an abnormal placenta. In other words, if the placenta is abnormal looking, fetus may be abnormal. So this we need to correlate. So this another placenta. Have a look at this placenta. This is the basal plate. This is the chorionic plate. Then you see the whole of the chorionic plate is filled with a slow-moving blood or the fibrin deposits. That means a lot of placenta is not utilized for its function. So you would expect some problem in this one, but the uterine arteries looks lovely diastolic flow. And you look at the blood flows again, vasculature again. So this placenta is full of blood vessels. Of course, as I said, this is subjective. There is no objective measure. You can actually do the vocal and look at the volume of the blood vasculature compared to the volume of the placenta, but it is too tedious and cumbersome. This another fetus, peripherally attached cord insertion, and appears to have some fibrin deposits. Uterine artery is slightly abnormal. And look at the blood vessels again. It's a little bit scarcity of the blood vessels. And if you do the VCIA, look at the grayscale and VCIA. So this is a gritty placenta. So you can use the VCI, the technology, into your armamentarium. And look, this fetus is 28 week, uterine artery is abnormal, and umbilical artery, PI, is very high, the diastolic flow is very, very small. Okay. So another placenta with, look at this hypoechoic lacunae. This lacunae, again, I'm reiterating, not participating in the business, and usually some slow flow blood will be there, and if you compress, they go away. So these are the surrogate marker of your placental function. If there are many, if there are more than 2 centimeter, and if there are more than 2, then it likely that it may cause problem. Again, many placentas will have this lacunae, but the baby is not bothered. So based on this lacunae alone, we should not make a management decisions. Oh, look at that. This baby has got numerous lacunae, but the baby's growth is normal. You may say that it is at 20 weeks, it may be normal, at 28 weeks may be abnormal. Look, at 27 weeks, also the baby is normal. That means this placenta is providing enough until 27 weeks. So likely that it is working very well. And look at the blood flows. The blood flows are beautiful, not just within normal limits. It's wonderful. The umbilical artery shows low PI, and MCI is normal, uterine arteries are normal. So you cannot make a decision looking at the appearance. That's my point. So this is another interesting case. So look at this placenta. The length is stunted or less, and the depth is high. So this is a hyperinflated placenta. Obviously, this is not working very well. Why? I'll tell you in a minute. Look at the uterine arteries, this umbilical artery or uterine artery. The uterine artery diastolic flow is very less. So PI will be very high. And the fetus also growth restricted. So the one thing which came to my mind is it looks bigger, but it is functioning. No. My professor in MBBS, anatomy professor, used to say, Akara Pusti, Naivedyam Vesti, Naivedyam Nasti. So this is a spice occupying lesion, not useful for anybody. So placenta not looking normal at all. So what is hyperinflated placenta? So hyperinflated placenta, so look at this nice placenta where there is a lot of working units helping in the exchange. But if it is short and stumpy, then number of units will be less. Obviously, you would expect some growth restriction. To understand this one, I got this from Dr. Manikandan, nice friend of mine. He's done a beautiful animation. This is a chorionic regression. So if you look at the developing embryo, the cytotrophoblast, syncytial trophoblast, tries and burrows the endometrium and makes a nice future placenta. Not, although the chorionic tissue is there all around, only part of it will stay back and the rest will go away. And the part which stays back is your placenta. So if sufficient enough chorionic tissue goes away, and if you have sufficient length and width of the placenta available, then this placental vascular unit works very well. And if there is excessive chorionic regression, the available placenta is very small. It may be thicker, but the length is less. So if it is more thicker and length comes down, then less amount of the business units are working, and hence you have a problem. If it is asymmetric, the peripheral cord insertion will come and circumvallate placenta will be also there. So now, I don't know whether I have time to go through. How much time I have, madam?
So how much do you need?
How much ever. I have plenty of cases. I can skim through. I think I'll skip this.
10 minutes. 10 minutes.
10 minutes, lovely. So, I mean, something called distal villus hyperplasia. It is no-brainer. If the villi is less and if the villi are not working very well, you have abnormal perinatal outcome. So if you look at the perinatal outcome in a blue color is a normal placenta, orange color is abnormal placenta, that is hyperinflated placenta. Rest everything, if you match, the perinatal mortality is higher in an abnormal looking hyperinflated placenta. Growth restriction also is higher. So there is some value looking at the placenta. Is there evidence? Yes. If you look at uterine artery PI, live birth rate, and severe FGR and distal villus, this is for pathologists. So as a clinicians, if matched everything but for the hyperinflated placentas have abnormal, significantly abnormal perinatal outcome. Okay, so that's about hyperinflated placenta. And I had taken presentation from Purvi and my Manju Sinha. Wonderfully, they presented, both of them presented placenta accreta spectrum, but don't think I have time for placenta accreta spectrum because that itself will take some time. So remove that presentation. Just for mention's sake, placenta accreta in a previously cesarean section, anterior placenta, you get see lot of lacunae and the bridging vessels, and the management depends upon so many things. One point I need to reiterate, if it looks so horrific, the diagnosis will be easier. If it looks so normal, diagnosis will be easier. Many times we will stay in between. So your gynecologist may ask you, what is it adherent? We should express our inability or limitations of ultrasound, even by MRI. We will not be able to predict all cases of severely adherent placenta or adherent placenta. Severely adherent, yes, we will know. But in the borderline ones, we fail. Why do we fail? And we should accept our failure and we should tell them there is a lower suspicion of accreta or a higher suspicion of accreta rather than being arrogant and say placenta looks normal, placenta looks completely abnormal, severely adherent. So we should play case-based and you should have a rapport with your gynecologist, and gynecologist should understand you and understand the limitations of ultrasound and work as a team. If you prepare very well for a severe messy outcome, and if you make a lot of fuss, you will not end up in mess. So all abnormal looking placenta, suspicion of adherent placenta, you prepare very well, including your surgical colleagues, urology colleagues, and interventional radiologists. Of course, sometimes all of them are waste, but if you prepare, then you don't get into mess. That's the point I want to make, and then I'll stop that one. The other problems you can get in an abnormal looking placenta is the vesicles. This is a 13-weeker. Look at the placenta. Placenta is a lot of small grape-like structures. This is a typical appearance of a molar tissue. Sometimes it's partial mole. That means the fetus develops, and likely that fetus will have some problem. So in this fetus, there is hypoplastic left heart syndrome. So the decision was relatively easier. What if the fetus looked normal, but the placenta looked like this? It is a difficult scenario. So look at this placenta. This placenta has got multiple sonolucent areas throughout the placenta. So what is this? Is this a molar? Is it a partial molar? Or is it a placental mesenchymal dysplasia? Look at this one. Part of the placenta is fine. Part of the placenta is abnormal. So is it a twin and dyed and formed like this? or part of the placenta looks abnormal. So there are a lot of difficulties and a lot of management dilemmas. You'll not be able to make a sure short clinical decision about the histological aspect of the placental appearance. So one important feature you want to look at is whether it is vascular or not. If it is vascular, it is more towards molar. If it is non-vascular or less vascularity, then it's more towards placental mesenchymal dysplasia. And obviously, all of you understand that we will not be able to make a clear-cut distinction prenatally. You may need to get some information and more information to make a decision. This is a 22-weeker. She's a doctor herself. Look at this placenta. Amazing. So, of course, even if you don't want to see the placenta, this will be glaringly visible. Question here is, if you don't give importance to look for placenta religiously in all fetuses, as small changes like, not like this, small changes similar to this one may miss. So you may want to pick it up. So if you're not looking placenta religiously, my request is to start looking at it. Whether to make a decision is entirely depends upon other features. Okay. This is a horrible looking placenta, and I don't want to bore you with the details of differentiation between the placental mesenchymal dysplasia and identiform mole. Both look similar. One is vascular, one is not vascular. Which is vascular? Obviously, the placental baby forming placenta like identiform mole will be highly vascular. Mesenchymal dysplasia, because dysplastic tissue, it may not have much of vascularity. There are a lot of chromosomally abnormal fetuses in identiform mole, but not many either. Placental mesenchymal dysplasia. Of course, it is associated with chromosomal abnormality. Sometimes Beckwith-Wiedemann disease syndrome also, because it's a placental overgrowth. In Beckwith-Wiedemann, all organs grow. So that may be correlating. If the baby is looking normal, size normal, unlikely Beckwith-Wiedemann. And biochemically, HCG and AFP you do. In identiform mole, HCG is higher, whereas in placental mesenchymal dysplasia, HCG is not that higher, AFP is higher. So this may be useful in making a differentiation between placental mesenchymal and molar pregnancy. So the other problem we can face is the chorioangioma, or the tumors to the placenta. So many of the placenta tumors are innocent, may not cause any problem. Some of them inside the placenta, some of them may grow. Some cause overload and cardiac strain and fetal death. And also they cause anemia because it traps the placenta, the thrombocytes. Effective load of platelets in the fetal circulation will be less, and they may have bleed and they may have anemia because RBC is also sequestrated. So for this reason, you may have to look at the placenta. If there is a tumor coming out, it's much easier. If there is a tumor inside the tissue of the placenta, it can be difficult. So 3 cases, if in 5 minutes, there's a lot of information I'll skip through because not required for this presentation. When you see this portion of the placenta is different from the rest of the placenta. And then when you put the color, this tissue, granular tissue, is next to the cord insertion. So your chorioangiomas, vascular tumors, are next to the cord insertion because they require a lot of blood. So that's why they develop where there is higher nutrition. This is like the banks of Ganga, where the fruits, the crops will develop nicer rather than the downstream. So this is a chorioangioma. It was not very typical of chorioangioma, but what else can be? It has to be a chorioangioma. And he also demonstrated it is that next to the hard insertion. So it is a chorioangioma. It is not causing any problem. We only worry. So although the size is bigger, we don't need to worry. But look at the vasculature. is highly vascular. That means it should cause problem or it might cause problem. So you look at the MCA. I said it may cause anemia because the RBCs and the platelets, both of them are sequestered in a useless area. So the effective circulating hemoglobin or oxygen will be less. So that will be shown by your MCA Vmax. So very high MCA Vmax was, close to high. Look at the heart. Heart is getting strained because this has to work to supply that tumor. There was cardiomegaly and pericardial effusion. And you look at the ductus venosus. This also tells that this baby is getting sicker. And you can do the cardiac function test by HQ. I will deal with this on some other day. It's a nice technology. So now, what do you want to do? There is a big tumor, very vascular, causing cardiac strain and severe anemia. So should you treat the tumor by either laser or RF? And what do you do with the anemia? Would you transfuse or would you do all of them together? Then if you did all of them, the cost goes up, the pregnancy loss may be higher. So there was a lot of dilemmas. So a patient went for a shopping and after 5 days, she comes back. And then I was presenting the HQ in Cardiacon. So this was a nice case to follow up with cardiac functions. Now the MCAV max has gone up. So that means in 5 days, significant deterioration is happening. Now what do we do? We decided we'll treat the cause, and if she's still pregnant, we'll transfuse later. Because if I transfuse and did the treatment together, we may lose pregnancy, and also this patient is not very keen to have the financial ability to take both of them, although we reduce the cost so much. At the cost of the instrument and apparatus, we did it. So first, we did a interstitial laser. Interstitial laser looks easier if somebody else is doing, but if you are doing it, your heart will be in your mouth. So one importance, this is the sampling, I think. You go next to the blood vessel. Yeah, this is a sampling to see whether the baby is really anemic or not. So the HB was 3 or 3.6, I think. So then we withdrew the needle away from the blood vessel, and next to the blood vessel, we started burning. So this is the blood vessel. You burn that area using a laser energy. So this effectively devascularizes. This is a feeding blood vessel. Feeding artery. So we have to burn next to the artery so that any blood coming into the tumor is taken away. So then, as soon as the procedure finished, look at that. Highly vascular tumor has become almost avascular. And then 5 days later, she was still pregnant. And then I saw her again. The cardiac strain is not completely gone, but it has already started showing ascites. Now what? So now we have treated the disease. We looked at the cardiac dysfunction. Cardiac dysfunction is getting worse. Next, the anemia is getting worse. So now the baby needs to be rescued. What do? We do the intrauterine transfusion. Don't know whether I have time to show you. It's a straightforward procedure. As I said, if somebody else is doing it, looks nicer. But if you're doing it, your life expectancy comes down every time you do the procedure. Okay, so nice transfusion, and MCAV max came down drastically after the transfusion, and sometimes it revascularizes. It did not revascularize, and then MCA getting better. MCA a few days later, again we saw, and the anemia was not completely cured, and the cardiac dysfunction is not completely cured, and we decided to do one more transfusion. And second transfusion, heart started looking nice, cardiac function looking nice, MCA is okay, and we demonstrated the nice cardiac function. And then I said, the patient was fed up of looking at me. Every time she comes, I will say something. I said, you don't need to come back. It is literally, I don't want her to see her because she need not to be seen in a bigger city. She was from 200 kilometers. I said, you will be looked after by your own doctor. Don't worry. And then finally, she's my ardent fan, the gynecologist. She sent me the picture, the huge avascular plus the placental tumor and a lovely pink baby. Everybody is happy. Okay, so this is one more, although it was a very small placental tumor, it caused a lot of polyhydramnios. That's why we decided to intervene. If it is not causing any problem, there is no point in intervening. So how do we intervene? You either have a radiofrequency interstitial laser or a radiofrequency ablation. So it depends upon the availability, and also we can do the glue. I'll show the glue next one. So there are 4: glue, radiofrequency, laser, and radiofrequency. This is a radiofrequency. It is like any other fetal reduction. You get the radiofrequency needle and burn the tissue. So you make it avascular, and gradually that becomes shrinks, and then disappears. So this is Saturdays. I didn't have much time to trim it. My nice fellow Sana did a little bit of Filmora and trimmed so many unnecessary things to give you a nice, precise way of doing glue. So this is a artery, and we took the needle next to the artery, and you prepare your glue, 5% dextrose and glue. So once you enter, you inject the 5% dextrose to fill up the column of the needle, and then you push the dye. And once you push the dye, it causes a coagulum of the arterial tree. Okay, so once you're in the blood vessel, you push the dextrose, that dextrose column is there, and then push the dye. That is N-butyl cyanoacrylate. And this dye, if it is gone into vein, you're done. If it is gone into the artery, it will form a glue in the arterial tree and makes this tissue avascular. Okay, so this is after the procedure. You can see almost became avascular, except a small. I was not brave enough to go to the card insertion site, because if inadvertently, if I push the glue into the vein, then I'm done. So we went to a little bit distal and devascularized about 90%. Only part of the tumor is vascular. I was not brave enough to take the needle and put it into other place. I was happy that 90% of the tumor is gone. So this is only Saturday. I'll tell you the follow-up later. Okay, fine. Now, how do we know placenta is working very well? So you can do.
So you really need to be a bit fast now.
Yep, finished. So this is my last slide. Somebody asked me why this way. I'll tell you. When we didn't have enough information and we looked at only placenta and made some decision. So we were looking eagerly the placenta. After the Doppler and biochemistry, we started showing the blind eye. Now, what we should do, I call it as a smart look. You can't show the blind eye. You can't be looking very intensely. You look at but smartly. Thank you.
Thank you so much, sir. Pratibha ma'am, would you like to say something? Then I would like to invite Mohit sir and K Shah sir also to give their comments. Dr. Pratibha Patil ma'am. Mohit Shah sir. PK Shah, sir.
Too long the lecture, madam. That's why everybody disappeared.
No, but they are there. So,
Okay.
I am very much.
hello.
Hi, Asha.
Sir, आपकी कमेंट का वेट कर रहे हैं.
Yeah, I'll do that. I think absolutely mind-boggling. All the videos and all the ultrasound pictures were just superb. And a very good talk covering the topic so beautifully. And I was thoroughly impressed with the quality of ultrasound pictures that Dr. Adi showed. Superb, absolutely.
Thank you.
Asha.
Good evening, sir. Sir, it was a wonderful talk. Thank you for changing another set of genes in our DNA. Amazing. Thank you so much for accepting the invitation, sir. We are very thankful for you for the presentation, sir. It was amazing.
You are my biggest fan, aren't you?
Thank you, sir. Yes, sir. Definitely. Always.
Sir, she cannot be the biggest fan, sir.
Okay, competition.
Yeah, there's a lot of competition here. Because when I didn't know F of fetal medicine, I heard you speaking on heterotaxy, then I heard it again and again. And, at least it's clear in my head now. So I will say there's a lot of competition there. Hello?
I'll always compete and always win.
Yeah, I'm now there. Yes. Sorry, I could not unmute myself. Adi, that was wonderful. And what was the most wonderful part was your schematics. You've done it wonderfully.
Thank
So my question to you is about the last case. So where you actually, the problem with gel foam is that it's very difficult to control as to where it can seep.
Yeah.
Yeah. So if it seeps out of the designated zone, it can actually cause more harm than the benefit. So
I agree.
how did you control that?
I'm not a great fan of glue. This is only the second case because we did use the glue for a monochorionic before actually laser came in UK, and we failed terribly. About 60% of the pregnancies we lost at that time for a monochorionic and feticide.
Yeah.
So that's why I'm not a great fan of glue. But this case, I wish I showed you ultrasound picture. What a beautiful, lovely, chunky, juicy vessel artery was there. Next to that is a juicy. You can see this one. The beautiful big vein is there. So I'm damn sure what is the artery, what is the vein, and where this artery is coming from, and where this artery branches are going. So I was more confident doing in this case rather than in any other case. And also, patient was poor, of course, and not all of them become poor when they come to doctor anyway. But they didn't have the financial ability to do radio frequency or interstitial laser. We could have done it at the cost, but still, this was clinically looking juicy, and I could do glue. So the question you asked is, how do you control? I'm damn sure that I'm entering into the artery, and the only way the blood can go forward. So whatever glue I injected cannot go back. So if I'm damn sure where I'm inserting, then the success rate goes up. So not always will be this vascular, this size vessels. So it will be difficult to get into the vessels. That's why glues will fail. In a case like this, if you get the needle, the success rate is higher. That's why I told you I did not want to go and devascularize or do a coagulum of the rest of the placenta. I was 90%, I was happy. And at the end of the procedure, the big vein collapsed completely. So before actually waiting for the outcome, I know that procedurally it is successful.
Good. It was wonderful. And the thing is that because you took 45 minutes, you had so much to show at your pace. So in a way, this becomes much better than giving lectures, where you don't have to hurry and you can actually do it at your own pace so that you get the message across. I loved your presentation, Adi, as usual.
Thank you.
Good.
Very nice.
Thank you, sir. And we are not, for normal gynecologists, obstetricians, this is useful to tell them that there is a treatment. Termination is not the answer all the time. You're not always going to lose the baby. Send the patient to a correct place and you will save the baby. So thank you so much, sir. Thank you for that.
You said normal gynecologists. Normal gynecologists don't exist. They are extraordinary gynecologists.
Thank you, sir. Thank you. If you would stop sharing, sir, I thank you so much and the chairpersons for being here. And I thank Mohit Shah, sir, and K Shah, sir, for being here through this whole program.
Thank you, ma'am. Pleasure's mine.
We enjoyed
Thank
it.
you.
Thank you, sir. Now I hope you will enjoy physiology as well, which is going to be
Sure.
basic.
Is it good?
So, Adi, sir, if you would stop sharing, sir.
It is not helping me, madam. Want to shout.
Yeah. So, ma'am, would you mind if I exit? I have another webinar to.
Thank you, sir. Thank you, sir.
So thank you so much, Dr. Asha. Thank you so much, Purvi. Thank you. See you soon. Bye-bye. Take care. Bye, Adi.
Bye-bye. See you soon.
Shah, sir. PK, sir.
Anji, bye.
Bye, bye, sir.
Yeah.
I think you should only stop sharing. Okay. Oh, now I got it. Yeah, yeah. Done. I'm out. Yeah.
Thank you, sir. So, Purvi?
Yes. For the second session, we have panel discussions.
Wait, I'm stop sharing. I'm going to share the correct one. I need to share the CVs, no? This is not working. If you would introduce the panelists in short.
Yes, ma'am. For the next session, which is panel discussion, I would like to first welcome our moderator, Dr. Asha Jain, ma'am. And then I would like to introduce the panelists. We have, firstly, Dr. Vinaya Maiskar, ma'am. She is consultant Obs-Gynae in Raipur, Afni Clinic in Raipur. She is author of many books, lifetime member of IMF, Foxy, IMS, ISAR, IFS, AMSAI, and speaker in many conferences. Next, I would like to invite Dr. Manjunath, sir. He's an assistant professor of Obstetrician in Belgavi. Then he is also a member of SFM, PCPNDT. He has many international publications and papers. His area of interest is high-risk pregnancy and fetal medicine. He has won many awards in CUSP, Chennai, and in cardiac quizzes all over India. Next, I would like to invite Dr. Varun Thakur, sir. He is MD Radiodiagnosis, Fetal Medicine Fellow under Dr. Adi, sir. He is FMF UK certified. He is also Secretary for Society of Fetal Medicine Greater Pune. He has won many prizes, many publications and papers in his name, national and international. Next, I would like to invite Dr. Kulbhushan Vishnoi. Sir is an MD Radiodiagnosis in Harda. He has many publications and papers in his name. He has been working as a senior resident in the past and consultant radiologist for MRI and CT scans in the past. He is also SFM executive member of Madhya Pradesh. Next, I would like to invite Dr. Suvarna Madam. Madam is MS OBGY. She is an assistant professor at Swami Ramanand Tirth Rural Government Medical College. She has also had post of assistant professor at Government Medical College Latur, director and consultant fertility specialist, endoscopic surgeon at GG Biradgar Memorial Hospital and Nimti Test Tube Baby Center Latur. Very warm welcome, ma'am. I would like to invite next Dr. Ashwin Rao, sir. He is a consultant reproductive medicine and endogynecology in Salem Polyclinic Private Limited. He has been National Coordinator FOXY, Executive Member OBGY Society of Salem, Executive Member Adolescent Committee, Executive Medicine, Executive Member Sexual Committee Member, and Peer Review Journal of Jogi. Next, I would like to invite Dr. Megha Karnik, ma'am. She is MS OBGY. She is working as Assistant Professor in Jawaharlal Medical College in Wardha. She has been Secretary of Devli Savangi Obstetric Gynac Society 24-25 and also Fellowship in Gynecological Oncology in JNMC. Very warm welcome, ma'am. Next, I would like to invite Dr. Divya. Dr. Divya is MS OBGY Assistant Professor, AIMS Deoghar, Jharkhand. First prize in Obs and Gynac Quiz in South Level Zone held at Chennai. Awarded Foxy Travel Fellowship in 2023. First prize for paper presentation at Kerala Federation of Obs Gynae. First prize for paper presentation in Mumbai. Published papers, presented posters, many courses on critical care obstetrics, interested in high-risk pregnancy and maternal medicine. I would like to invite all the panelists. Very warm welcome. Ma'am, hand over to you. Ma'am, you're muted. Still muted.
Vinaya, can you unmute yourself?
Yeah, I'm unmute now.
Yeah. You're muted again.
Am I there now? Audible?
Yeah. Yes. First question goes to you. Why is FGR significant in perinatal care?
Yeah, fetal growth restriction is basically the failure of the fetus to acquire its full growth genetic potential, you know. So, or we can say sonographically, it is less than 10 percentile expected fetal weight for that gestation, or less than 10 percentile abdominal circumference for that gestation. It is very significant because it corresponds to or contributes to significant perinatal morbidity and sometimes perinatal mortality too. So it is very necessary that the fetus matches with the growth as per the gestation. And it's the duty of the obstetrician to pick up FGR early.
Okay. So thank you so much. Now the next question is, what are the primary recommendations of FIGO for screening FGR?
Yeah, ma'am, may I take this?
Please go ahead.
So we has ma'am told the importance of FGR, detection of FGR and its role in having the perinatal morbidity and mortality becomes a very important step to screen for this FGR. So with it should be a universal screening rather than the optional, where all antenatal women who come to the antenatal clinic should be offered a uterine Doppler in the first trimester along with the NT scan, and we should send a double marker which will assess the uptake along with the addition of the placental-like growth factors. And nowadays, we are even doing a study on the ophthalmic artery Doppler in assessing and predicting the risk for preeclampsia and FGR.
Okay. So now, how does the human placenta function as a barrier and facilitator for drug transfer? Because we are talking of blood, but how about drug transfer? Please unmute yourself, Dr. Varun.
So, good evening all. It
Good
is
evening.
basically through the basic physiologic mechanisms like passive diffusion, active transport, facilitated diffusion, and penocytosis. And of course, it is determined by the lipophilicity of the drug, its ionization status, and its molecular weight.
Okay. So all that is through the medium of blood. And that is why, because it's all happening through the placenta, we are talking now about the placenta and its function. So this is, Adi sir has said it very well. If Dr. Kulbhushan, if you could just describe the main functions in short so that we remember it again.
Good evening all. Thank you, ma'am. So the main function, as Adi sir has told clearly, the main function is nutrient supply. And with that, gas exchange, waste removal, immunological protection, and hormone secretions.
Okay. So when we are talking about the next question goes that from fertilization to 12 weeks, this is what Adi sir has shown in his small video. But if somebody could describe it in a few sentences, the placenta from fertilization to 12 weeks, how does it actually develop? Because we see the placenta at 12, we don't see the placenta in the beginning. Dr. Suvarna,
Hello.
are you there?
Yeah. Hello. Okay. Am I audible, ma'am? Hello.
Yes, you're
Hello.
audible.
Yeah. Dr. Suvarna here. Thank you so much. Good evening, everybody. Am I audible, ma'am?
Yes, ma'am,
please
you're audible.
continue.
Yeah, sure.
Yes.
Actually, development of a placenta is a very long process. Very rightly said by Dr. Adi sir, we cannot enumerate in a period of 45 minutes. I have got only 45 seconds to answer. In the development, actually, as we all IVF consultants and all, we know the development of the placenta actually starts immediately after the fertilization. It starts after 3 days of the fertilization. Basically, to understand the physiology of development of placenta, we should know two basic terminologies. That is, what is implantation and what is decidualization. Implantation is the burying of the formed embryo inside the functional endometrium, that is decidua. To shorten the things, I'll tell you, during the process of implantation, the day 3 embryo, after it forms blastocyst on day 5, the trophoectoderm layer, trophoblast layer of the blastocyst buries inside the decidua and it forms some space for it, and that trophoblast again differentiates into cytotrophoblast. And once it starts expanding and growing inside the decidua basalis, decidua parietalis, and decidua capsularis, such layers are formed. Mainly the decidua basalis and the chorionic villi developed from the trophoblast, and since cytotrophoblast take action into the development of placenta. Like we know other villi get disappeared and only villi on the side of the decidua basalis will remain like that, which will form chorion frondosome. Chorion frondosome and decidua basalis have a lot of interaction in between and they will form the placenta, that is maternal fetal surface, like primary villi, secondary villi, tertiary villi, and some anchoring villi. There are some almost 12 to 13 to 14 cotyledons inside the placenta with lots of anchoring villi inside. And basic role of anchoring villi is to supply. And one more important thing, in between the intervillous space, which we call as lacunae. That is the space which is filled with maternal blood, and that is the space where the diffusion and perfusion across the feto-maternal surface will happen. This process keep on going till 12 weeks. 12 to 14 weeks, there will be complete formation of the placenta, and later on will keep on growing.
Thank you, Dr. Suvarna. Now, I have a question which is not here on the list.
Yeah.
Can any of the fetal medicine people tell me, is it possible to identify placenta previa in the first trimester? Any of the fetal medicine people to tell me, is it possible to identify placenta previa or chances of placenta previa or placenta accreta in the first trimester?
Placenta accreta, yes. But I mean, if the sac is low lying and if the chorion is very close to the previous scar and if it is appearing to be invading the scar, then we should mention in the report that the likelihood of accreta or an adherent placenta needs to be considered, and that lady needs very frequent follow-ups. Placenta previa, many of the placentae, because the uterus is small in the first trimester, may be on the, they may be on the lower side. So previa by definition is actually beyond 28 weeks. So if the placenta persists to be low lying beyond 28 weeks, then maybe I would like to label it as a placenta previa. Until then, I would simply mention its distance from the internal os.
Right.
So supposing it is covering the internal os, what would you say?
I will say placenta is low lying and it is completely covering the internal os.
Okay, but you would not label it as previa.
I would refrain from writing as previa until and unless it has crossed 28 weeks, because till then it is, there are significant chances that it will migrate up.
So thank you so much for that. Now we come to question number 6. What are the factors that influence drug transfer across the placenta? Dr. Ashwin?
Basically, the points which influence drug transfer are the molecular weight, and then the solubility in fat, that's lipophilicity, degree of adhesion and protein binding, and mainly about the availability of transporters through and across the membrane of the placenta.
Okay, so would there be any difference in transfer in the first, second, and third trimester?
Generally, I think the transfer is better. I ideally see in the second and third trimester compared to the first. But although it involves the growth, actual maturity and development in the first trimester, I feel transfer is better in the first, second, and the third, because that's when we come across IUGR and the other complication of pregnancies.
Okay. So anti-epileptic drugs, you have patients who've been taking anti-epileptic drugs, they don't even know that they have got pregnant and they have come to you. So in these patients, how do these drugs cross the placenta and what are the effects they have on the fetus?
Good evening, ma'am.
Yes, Dr.
Yes. So anti-epileptic drugs, they are less ionized. So depending upon the ionization of any drug, these drugs are going to cross across the placenta. And if they are given, and if the woman is taking those anti-epileptic agents right since her preconceptional period or periconceptional period, she is at a risk of having two syndromes very commonly used, valproate and phenytoin. So she is at a risk of having, the baby is at a risk of having fetal hydantoin syndrome and fetal valproate syndrome, wherein it is associated with neural tube defects. There are facial defects, CVS defects, and there can be limb defects. So all in all, it can lead to CNS defects and musculoskeletal facial defects if anti-epileptics are given in the periconceptional period, as she is unaware about these anti-epileptic agents.
Okay. But supposing she is aware and she has come to you for preconception counseling, what would you advise? What would you advise? If she stops the drug, she gets grand mal seizures. So what is your advice going to be?
So for such a patient, we would shift to a slightly safer anti-epileptic. None of the anti-epileptics are safe, but the one which is less harmful, like carbamazepine, or we can give her yes. So we can give her levetiracetam. So these are the slightly safer anti-epileptic agents, and closely monitor her. And along with that, give her high dose folic acid so as to prevent these neural tube defects, especially.
So the one thing you're not giving her is valproate. If she
Yes, ma'am.
comes to you before, you want to stop that for sure.
Yes, ma'am. Yes, ma'am.
Okay. So now we come to next question. What are drugs that are considered safe in pregnancy?
Good evening, ma'am.
Good evening.
Ma'am, actually, common medical condition or diseases can occur to anyone at like during any time. So even during pregnancy. So it can be an acute condition or a chronic condition, and we are relatively risk-benefit ratio, whether it's safer for the baby also. We should treat the patient, and we should consider a drug which is like safer when we consider the fetal malformation also. So there are we should say like it's a safer one when according to that condition. So it can be like for fever, we can give acetaminophen, and we will be giving levothyroxine for hypothyroidism. We can give insulin, and for hypertension, we can give methyldopa, nifedipine, and like antibiotics, including penicillin, cephalosporins, etc.
Okay. Okay. Thank you for that. Now, which drugs are you not going to give? Dr. Vinaya, I come back to you. Which drugs are we not going to give in pregnancy?
Actually, there is this classification for safety of drugs in pregnancy. As we all know, A, B, C, D, and X. So A category is generally safe, and B is safe if the patients, you can use it if the benefit is more than the loss. And C and D are to be avoided. We know like isotretinoin, like valproate, like lithium, antipsychotic drugs. So some drugs are proven that they are going to cause thalidomide, they are going to cause teratogenicity to the baby. So some few drugs we should avoid in pregnancy.
Okay. Okay. These days patients will be taking protein powder, iron, multivitamin, without asking any doctor, right? Previous to getting pregnant also. So do you want them to continue with all these portions, or you want to stop everything in her first trimester?
In first trimester, we should not give multivitamins because that contains, we would like to avoid vitamin A kind of things. We don't want all the vitamins to be given in first trimester. First trimester, we should restrict ourselves with folic acid. And if she needs a progesterone support, if she needs some vomiting medicine or something like that, or maybe thyroid issue. So we should keep a minimum prescription in first trimester.
Okay. So now, Dr. Manjunath, this is for you, but I don't know if you're the right person to ask this. Are there any drugs that are safe in one trimester but unsafe in another?
Yeah, definitely, ma'am. As we all know that the majority that the embryogenesis occurs within 9 to 10 weeks of a pregnancy, as ma'am rightly told that avoid as many as drugs possible in the first trimester except for folic acid. Now, what happens here is there are certain class of drugs which are absolutely contraindicated in few trimesters. Example, if you take nitrofurantoin, which is given right-left for the urinary tract infection. They say that it has to be avoided after 36 weeks, which is known to cause hemolytic anemia in the newborn babies. One, and comes with the anticoagulants like warfarin, which is which is to be avoided in the first trimester because of warfarin embryopathy, and like NSAIDs, which have to be avoided in the later trimester when we give it for the polyamnios, because where it can lead to premature closure of the ductus arteriosus. So when we are using the drugs, we have to be very selective, and if required, then only it has to be used.
Thank you so much. Thank you. So now we proceed to the next question. And, torch tests are done. You do a torch test once and the patient keeps doing it. They don't even ask the doctor. They think they have had an abortion because of torch and they keep doing it. So if we are talking about rubella, how does the risk of rubella infection vary across trimesters? Means if it is in the first trimester, if it is in the second, or it is in the third. When are we worried about rubella?
So it is highly teratogenic in the first trimester, because if it happens then there are high chances that the child will develop something called as congenital rubella syndrome. In the second and third trimester, the risk of congenital rubella syndrome decreases substantially.
So if a patient comes to you with a torch report and she is 20 weeks pregnant, right? And her rubella is positive, and she's asking you, even though you say no, you ask your gynecologist, she's asking you that, will this harm my baby? What is the answer going to be? In the second trimester, at the mid-trimester anomaly scan, she has come with a positive torch report. Ashwath, you want to answer that?
I can take that. Basically, the only thing I'm even worried about is fever with rubella, which might cause some amount of preterm. And some rubella, uninfected mothers can have something called a sudden infant death syndrome, which is not necessarily with with diabetes. Can happen in this as well because of congenital rubella infection, which can happen and spread through the membranes. Because since viral loads can go high and can cross the placental barrier, you can have some amount of IUD with rubella.
Okay, so the take-home point here, as I understand it, is that in the first trimester, you're worried about congenital rubella syndrome, but after that, you have to observe for sudden infant death syndrome and perinatal mortality, right?
Yes, and IUGR as well.
And IUGR. So now we come to the next torch infection. What are the effects of toxoplasma infection during pregnancy?
So, as said previously, basically we're looking for again congenital infection, especially again contracted in first trimester. So what we look for is ventricular. We look for the ventricle walls, ventricle dilatation, any calcification in the brain, and we can go for the secondary signs like hepatosplenomegaly, ascites, any effusion, or any free fluid elsewhere.
Okay, so if this toxoplasma is contracted in the first trimester, then what happens? And if it's contracted in the third trimester, then what happens?
If it's contracted in the first trimester, then we'll get these fetal signs easily diagnosable in the ultrasound. And later in the pregnancy, they are less likely of seeing these ultrasound signs for infection.
Anybody wants to add anything to that? So now we come back to the next question, that what is a congenital rubella syndrome? What is it? Yes, Dr. Suvarna.
Yes, ma'am. Congenital rubella syndrome, it is actually triad which involves eyes, heart, and ears. If it has early onset also and late onset also. If it is occurring in early trimester, it mostly affects the eyes, like congenital cataract, chorioretinitis, or microphthalmia can develop. In heart anomalies like patent ductus arteriosus or pulmonary, severe profound pulmonary stenosis can happen. And in a patient, that baby can suffer from sensorineural deafness also. And in late onset cases, we can come across FGR, some hepatosplenomegaly like conditions, jaundice, endocrinological disorders like hypothyroidism, or in later life, the baby may develop diabetes mellitus also. And actually, we are focusing on the triad, congenital rubella triad.
Okay. So there's a second part to the question, that how do you prevent rubella infection?
Actually, rubella infection can be prevented by vaccination before pregnancy only. Once the patient comes to you, actually after 26 weeks, if your patient has contracted the infection, there is very less risk of having the manifestations in the fetus. But most of the time it comes before only, and only we have 24 weeks cutoff. So there is no other way out. Only before pregnancy vaccination is the only thing which can save.
Yeah, so the government gives MMR vaccine to children at 15 months of age. Now, the only thing is it needs to be repeated at 15 years.
Yes.
So if we are able to repeat that at 15 years, this congenital rubella syndrome can be taken care of. And any patient who comes to us planning to get married or preconception counseling should be given the vaccine.
Yes, and should avoid pregnancy for next 1 month at least after vaccination, preferably for 3
Supposing
months.
she gets pregnant, then what? Do you advise her an abortion?
No,
Actually,
not
it is a live vaccine, so she should not continue, I think.
no. We can continue with the pregnancy. She can continue with the pregnancy. It's a live attenuated vaccine, so no need to fear for
So there is
CRS.
no need for abortion. That is the
No
point
need
I
for
wanted
abortion.
to bring up.
Yeah,
Okay.
no need for abortion.
Okay. Now, how do you prevent toxoplasma infection during pregnancy? How do you prevent? Ashwin, it's to you, I think.
Yes, ma'am. So toxoplasma, I mean, basically it's transmitted through cat feces. So I feel maintaining proper hygiene, keeping your surroundings clean, trying to avoid tabby cats, and other cats on the road trying to come in and stick around at your place. Make sure your house is clean with not many sweets because I mean mice attract cats anyway. Those are a few things we done, and then again, I mean, food cook being for if you're somebody who eats meat, then proper cooking of your food would really help to avoid toxoplasma.
So one thing I want to ask you, a patient had toxoplasma infection in her first pregnancy. Now she has aborted. Now she is planning a second pregnancy. That was a spontaneous loss at 14 weeks, right? Now
Yes.
she is planning to conceive again. What would you advise her? Would you give her any medicine? Would you do any test?
Ma'am, nothing as such, but I'll probably check for her toxoplasma IgG levels. That is one thing. And toxoplasma IgG, if it's good, then obviously the chance of, I mean, of getting affected again is pretty low. And then if you do think that, I mean, she's somebody who is a cat lover or something, prophylaxis can be given if you think of some kind of, if she's going to be infected. The cat can always be taken to the vet for one visit to assess for toxoplasma. And then, I mean, anti-worming can be done for the cat. In fact, even in case it's a pet.
Okay. Okay. Thank you. Well, I just wanted to know your opinion about spiramycin.
Spiramycin is more, I would not really say prophylaxis as such, but if you have toxoplasmosis during second or third trimester, then probably it can be done as a way of management as such, but it's not really prophylactic.
Okay. Okay. Thanks for bringing up that point. Now we come to cytomegalovirus. How does CMV infection affect the fetus?
So, CMV infection, if it occurs in the first trimester, then it can lead to sensory neural hearing deafness. It can lead to developmental delays in the child, and it can lead to microcephaly. These are what happens if there is infection in the first trimester.
In the second?
So, in the second and third trimester, there is not much effect because of the development of the placenta. So, the maximum effect of CMV is on the fetus when it is developing in the first trimester.
Okay. Anybody has any experience of parvovirus infection? To the fetal medicine people, I would like to ask you, what do you see in parvovirus?
There'll be generally anemia because that's what how it generally manifests. So, and if there's severe anemia, then the child may have hydrops. We had one patient with hydrops, and the mother was Rh positive. So it was a non-immune hydrops. Rest all other causes were ruled out. We even did a whole exome for her. We even asked her to do a parvovirus B19 PCR, but the couple was not so willing and they were not affording. So that was the only stone which was left unturned. So we assume that was probably because of parvovirus B19. So that's one thing which we will be worried of if we have a known case of parvovirus B19 infection, anemia.
Okay. So fetal anemia will have two differential diagnoses. Now, what happens when the mother gets varicella or chickenpox infection during pregnancy?
So, regarding the chickenpox infection during pregnancy, we should categorize the risk for the mother and the fetus. So, mostly this chickenpox is seen in childhood age group, and if it occurs in the adults, it will be having more morbidity, like there will be pneumonia, risk of pneumonia, encephalitis, and hepatitis. And going to the fetal side, like we can divide into two sets, like in the early trimester, like first half of pregnancy, and towards the end of the trimester. So when it occurs in the first half of pregnancy, there is a risk of varicella, fetal varicella syndrome. And in this, baby will be having ophthalmological microphthalmia, neurodevelopmental issues, and hyperplasia of limbs and all. And towards the end of the pregnancy, means like last 4 weeks of pregnancy, if there is chickenpox infection, then there is a risk of neonatal varicella syndrome. So if better if she is infected, we should wait for more days so that the baby will get the immunoglobulin, so that we can somehow somewhat prevent the condition.
Okay. So I have a very basic question that do all these infections cross the placenta?
No, ma'am. No, ma'am. It's less than 1%.
Okay. So that is the very important thing, that 99% of the time you are not worried. You have to keep alert, but you don't want to abort a pregnancy because the mother got varicella. Am I correct in that?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
You should know the communication.
So now there is herpes. The mother has herpes. How is neonatal herpes transmitted and what are the implications for the mother and the baby? Yes,
Yeah,
Vinaya?
neonatal herpes is transmitted through the genital secretions. If the mother undergoes a normal labor, then the secretions, they will be secreted over the child. And then the manifestations are mostly eye, skin, and CNS manifestations. In skin, there are small blisters or pustules, you can say small fluid-filled, and lesions. And eye also, around the eye, around the lip. So that are the
Are these transmitted across the placenta, or it has nothing to do with the placenta?
No, it is during normal delivery. So normally if the mother has herpes simplex, we suggest that you avoid a normal delivery. So they should be for.
Okay. So now we go to the next. If there is malaria in pregnancy, then how do you manage that? What effect do you see on the placenta in a case of malaria?
Ma'am, malaria per se on the pregnancy, it can affect either mother or the baby, fetus, both. In the mother, yes, right from the basic, it can lead to hyper fever episodes are very common, which can lead to hyperpyrexia. It can lead to jaundice, pallor, anemia because of hemolysis. It can lead to renal failure, pneumonia, encephalitis, and certainly some conditions it can even lead to convulsions, coma if left untreated. And in fetus, yes, we have got FGR because of affection to a tertiary villi. It can lead to
See, the
FGR.
malaria parasite is a very big parasite. Does it cross the placenta?
No, ma'am. No, it just causes the inflammation. Basically, it is not crossing, it is just the inflammation because of the reduced immunity.
So that is an important point, because today our topic is placenta. So I'm asking you, whatever happens to the mother, but are we transmitting the malaria parasite into the fetus? So we are not transmitting that. It is the effect of the mother that is harming the mother, the fetus. Ashwin, you want to add something there?
Actually, basically, but falciparum malaria can, they're saying the microfilaria can close the placenta as one. It's been found and cause placental malaria. There's few papers on that as well. So they're saying that any malaria diagnosed early has to be treated early is what they say. Not that nobody's going, not that anybody's going to treat them late, but falciparum malaria can cause further IUGR and fetal death also is what they can say.
So that is the important thing. Vivax does not cross, but falciparum does cross. Falciparum malaria will cross. And now, what about hepatitis?
So it can cause vertical, there can be vertical transmission to the fetus and then it can affect the newborn, of course. So it can be prevented by giving the hepatitis B immunoglobulin to the infant, to the newborn, and also by vaccinating.
Okay, now if the mother is pregnant, she has a hepatitis B titer of more than 20,000, right? She has a huge viral load. What can we do to prevent the baby being affected?
She can see a GI medicine specialist, and of course, if the viral load is too high, they can put her on antivirals. Like amiodarone or tenofovir.
See, but the point here is that the virus is not transmitted via the placenta. That is why the blood-to-blood transfer has to be avoided. So there should not be a blood transfer even during delivery. We have to avoid that, and then you immediately give the immunoglobulin to the baby. So you treat the mother, that is for sure, but the virus per se is not crossing the placenta. Correct me if I'm wrong. What about typhoid, which is endemic in our area?
So, ma'am, like as you said, what we are bothered about is the fetal loss and the preterm labor. So it's the as you have explained that it's better to treat the mother with antibiotics and avoid any further complications.
Yeah. So typhoid has an effect on the mother's GI. So we want to avoid maternal complications and give antibiotics. Which antibiotic do you think we can give here?
We can give ceftriaxone or any.
Yes, ceftriaxone is safe. We will not want to give the levofloxacin, ciprofloxacin group in pregnancy.
Ototoxicity.
Anybody wants to add anything to that? If she is HIV positive, now what do you want to do? If a woman is HIV positive, then what do you want to do? You
In
don't
HIV
want the baby to get the infection. So what are you going to do to avoid vertical transmission?
Yes. In HIV positive cases, we should get that lady should get proper antenatal care and even proper obstetric management. Add on to that, we should look her for viral load. If viral load is very high, she should get antiviral therapy like zidovudine, which is the most preferred therapy, and we can even add protease inhibitors if required with an opinion. And we should avoid, as it has a high chance of vertical transmission and through genitalia, we should avoid 100% should avoid normal deliveries. We should do a planned cesarean section. And even in such cases, there is chances of transmission through breastfeeding. So if other options are available, breastfeeding should be avoided. Even instrumental deliveries, traumatic deliveries should be avoided.
Anybody wants to add anything to that? Anybody here? Any of my panelists want to add anything there?
Ma'am, regarding lactation, like exclusive, like we prefer to give formula feeding, but in India, like we can advise them to have exclusive breastfeeding, and we'll give nevirapine to the baby also.
Yes, so we give nevirapine to the baby, and 100% the woman will have to be on antiretrovirals. 100%, not depending on her viral load. She has to be on antiretroviral.
Yes.
Okay, irrespective of her viral load.
And she will be on TLE regimen throughout her lifetime.
Yes. Any other infection that we are worried about in pregnancy? Any other infection?
One need to talk about is Zika. Because that is something which can cause fetal neurological deficits. So again, mosquito management, I mean, like malaria, like dengue can also cause, can cause hemorrhagic fever in the mother and also cause, bad poor outcomes in the baby as well. So I think mosquito borne and zoonotic infections can be something that we can talk about.
Okay. So mosquito management, that means water not to be collected.
Yes, ma'am. Water
No dark
collection.
spaces.
Yes, ma'am. But I don't know how, and I mean, having proper drainage systems, but how far it's feasible in India is something that we have to really question. But otherwise, that's something that we have to really plan.
Yeah, at least you can use a mosquito net, right?
Repellent and net, yes, ma'am.
That at least can be used.
Yeah.
Okay, thank you very much for the advice.
So now we come to the next question. When should a pregnant woman with fetal growth restriction be delivered?
So when we have a baby who is having FGR, the first thing is we are going to regularly monitor this baby, and
Actually, Megha, what I want you to answer me is, the trigger.
Trigger.
If it
Okay,
is
yes, ma'am.
early FGR, what is the trigger? If it is late FGR, what is the trigger? When you want to deliver this baby? Monitoring and all we've already covered. So
So
what
we
are the
will see if there are any abnormal Doppler changes. So if we find that there is umbilical artery absent flow or reversal of flow, if there is a rise in the mean PSV of the middle cerebral artery, or if we find that there is absent flow in the ductus venosus, then we have to deliver the baby. And if the Doppler is normal, then we will give corticosteroids, antenatal corticosteroids, and then pull on the pregnancy till at least 34 weeks and then deliver the baby.
Okay, Vinaya, would you like to add something here? What is a trigger in case of early FGR?
Early FGR, basically we need to see the biophysical profile on ultrasound, the fluid.
Early FGR.
We should put them in a Barcelona staging for IUGR.
Yes.
Yeah. Stage 1 to 5, we should categorize them into stage 1 to 5, and it gives us whether to at what gestation and what Doppler abnormalities we should induce.
In early FGR, which is before 28 weeks, your trigger is the ductus.
Yeah.
Okay, the ductus flow is the trigger. When it is late FGR, then when you're doing a biophysical profile or a CTG, they are your triggers. In biophysical profile, if the breathing movements are compromised, in a CTG, variability is compromised. You have to monitor accordingly. So it's different in early FGR, in late FGR. In early, it is because, as Adi sir had explained in his placenta, and we did it before as well, there is adjustment on the part of the fetus in early FGR because it's been going on for long. So there, the umbilical and MCA will have adjusted. You need the ductus there. But in late FGR, the oxygen sensors are important. So there, your whatever is basically the oxygen levels are getting low. The triggers that show that is decreased fetal movement, decreased breathing movement, and decreased variability. They are your triggers. So now, when are you going to give corticosteroid? When are you going to give corticosteroid? Which weeks?
Ma'am, corticosteroids are recommended from like 24 to 34 weeks of gestation when we are expecting a preterm delivery within a period of 7 days. And after 34 weeks, the giving corticosteroid is controversial because the benefit is not so good because we are not getting a better outcome with regards to the survival or respiratory outcome. But there is a long-term neurodevelopmental issues.
But here my question is very simple. 24 weeks or 28 weeks?
24 weeks to 34 weeks is the recommended one. If you're having a good NICU facility, then ma'am, of course, after 24 weeks, the survival rate of the neonate also will be good. So we can.
So basically, it will depend on your NICU. If your NICU can take care of 24 weeker, then though it is useful. Otherwise, it's a wastage.
Yes, ma'am. Yes, ma'am.
So here the trigger is basically your ICU. Whether your NICU can take care of a baby that is 500, 600 grams.
Yes, ma'am. Ma'am, and one more thing regarding the betamethasone and dexamethasone, the drug we are getting is betamethasone sodium phosphate.
Yeah, so we give dexamethasone as per Government of India guidelines. That's it. Now, if there is fetal growth restriction, when are you going to do expectant management? You're not going to deliver. You have looked at her placenta. You have her Dopplers. When are you going to ask her to come for follow-up?
Yeah, if the Dopplers are normal, basically at this stage, the blood flow is important. So if the Doppler studies are normal, then we can wait. And secondly, on CTG, as you said also, and
if it's an FGR, you will have Doppler abnormality. So which stage of abnormality you will still wait?
High resistance flow will wait, I think, ma'am.
Excuse me, who
High,
said that?
Ashwin.
Yeah, Ashwin, tell me.
High resistance flow, I still watch and monitor on a weekly basis, but if it's absent or reversal of flow, then definitely deliver for umbilical.
So, depends on the age of the fetus. Even in absent, you might wait.
But provided you're able to have the patient come to you every 3 days in absent.
No, you have to keep her hospitalized.
Hospitalized. If you're waiting with reversals and absence, then the
No,
patient should
you
be
cannot
hospitalized.
wait for beyond reversal, but
Yes.
you can wait for absent end diastolic flow. You can also wait for
high end diastolic.
High resistance. High resistance weekly is well alone, ma'am. Yes.
Yeah. So if there is a woman with mild preeclampsia, mild, her BP is like 130/90.
Yeah, ma'am. If it's a mild preeclampsia without severe features like BP of more than 160/110, no evidence of any help like hemolysis, low platelet count, elevated liver enzymes. She is not having any features of Press syndrome. There is no abruption. Okay, so we can definitely do a conservative management till 37 weeks of gestation with a close monitoring, definitely, of the mother and the baby.
Okay. Okay. What antihypertensive drugs can you use?
Methydopa, labetalol, nifedipine, hydralazine. So these are the drugs which are safe in pregnancy.
That's all. So what are we not using? What should not be used?
AC inhibitors.
Yes.
And
Delmethadine is not to be used. Yes. Okay. ACE inhibitors are not to be used. Which antibiotics are generally safe?
Penicillins, cephalosporin, erythromycins. These are safe.
Okay. Which erythromycin is safe? Because not all erythromycins are safe. So now we come to the fag end here. Hard drugs. If the mother is taking alcohol during pregnancy, what happens to the fetus?
Actually, alcohol is a very highly lipid soluble drug. It crosses the placenta very readily. So it has lots of effect on the fetus in first trimester and second, third trimester. If the fetus is exposed to alcohol during first trimester, there are more chances of development of facial abnormalities and some cardiac defects. And if the fetus is affected, this is all called as fetal alcohol spectrum abnormality spectrum disorders, FSAD. And if it is affected in second or third trimester, there are more chances of developing FGR and even brain developmental abnormalities, which will lead to in later life, there will be behavioral problems or cognitive disorders the baby may have.
Okay. And what about tobacco?
Tobacco.
No. Yes, Ashwin.
Yes, tobacco is basically associated with severe vasoconstriction, so it can cause. Again, the high risk of preeclampsia is one thing. I mean, preterm FGR, and then abruption and stillbirths. What is associated with tobacco, whether it's smoking or it can also be tobacco chewing as well.
Okay, so any form of tobacco is bad.
It's bad, yes.
Any form. And what about cocaine, Megha?
So cocaine, as in adults, it causes vasoconstriction. Same way at the placental bed, cocaine causes vasoconstriction. So that can cause oligohydramnios. It can cause FGR. It can result in premature preterm labor, and it can also cause abruptio placentae. And in the fetus, there can be something which is called as a withdrawal for the fetus, which can result in depressed breathing, can lead to convulsions and hyperactivity in the newborn.
Okay. Okay. So again, any hard drug is not to be used. But what about opioid use?
Opioid, opioid also transferred through the placenta. So this can result in preeclampsia, abruption, stillbirth, preterm delivery. Other than that, it can cause neonatal opioid withdrawal syndrome. That is neonatal abstinence syndrome. So baby will be having transient withdrawal symptoms like poor sucking, crying, tremors, vomiting, diarrhea, and all. So this baby should be observed over a period of 5 to 7 days in the neonatal ICU.
Okay. So now, very many patients are taking SSRIs. These days, depression has become fashionable. So after Deepika Padukone popularized it that I was in depression, many people are taking these depression medicines. Do they affect fetal development, Vinaya?
Yeah, they cross the placenta and they certainly affect the fetal development. A baby will have neonatal adaptation syndrome and neurodevelopmental delays and cognitive patterns. So they are certainly not very helpful to be continued in pregnancy.
Okay. Okay. So how will you manage as an obstetrician? How will you manage the side effects of stopping the medicine?
We can switch on to drugs which are more safe in pregnancy, because these category of drugs, all of them are C or B like that. So, so we may probably shift to a better drug, which is more safe and mild. And we may also introduce counseling to the patient, because psychological counseling is very helpful in such patients, that she has to understand her baby and pregnancy is more important. And probably.
What about malaria? How do you treat malaria, Dr. Manjunath?
Yeah, ma'am. We have got a very safe anti-malarial drugs in the pregnancy, and the gold standard drug, that is drug of choice, is the chloroquine, which is available, which can be given as a 600 milligram start, followed by again 6 hours, 300 milligrams, and later for 2 days we can give that.
Yes, so basically, what you are saying is chloroquine is safe in pregnancy.
Yeah, chloroquine is safe in pregnancy, ma'am. And if it's a drug resistance chloroquine, then mefloquine is advised.
Okay. What about hepatitis C? Can we do anything for hepatitis C, Varun?
We have to simply manage, we have to simply look at the LFTs and look at the viral load. We don't give treatment until she's delivered, or if the liver is severely deranged or damaged.
Okay. So this, I think we've already taken. Antiretroviral therapy in HIV.
Yes, ma'am.
Must be given.
So it has to be continued. This is also done. Maternal rubella infection.
Yeah, ma'am, I want to add one thing in rubella vaccination. If it is not given in the childhood, we can even give in age group of 19 to 26 years.
Yes.
Yeah, before marriage. Yeah.
Now, what about syphilis? What are the effects of untreated syphilis during pregnancy? Ashwin?
Syphilis is basically, as we see as of now, I don't know, over the last 6 months, I've been seeing a lot more VDRL positive and triple antigen positive over the last recently. Benzathine penicillin can always be given and managed, but basically what we see with syphilis is some patients come with just complaints of white discharge, but it can progress to secondary and tertiary syphilis. Tertiary syphilis can lead to aortic dissection as well in the mother. It doesn't significantly affect the baby as treponema are quite large and don't really cross the placental barrier, but it affects the mother and causes complications in the mother.
You remember when we were kids and we were studying, it was told that, if you have syphilis, then gradually the duration of pregnancy keeps on increasing and you get multiple miscarriages. Remember?
Yes,
if it is untreated. So we have to treat it. That means we have to be alert about it. And whenever we have a doubt, we need to test, or at least the baseline tests need to be done.
And check the partner also, because the partner might be the actual cause.
Yes.
For maternal.
Yes. What about CMV? Do we manage it in pregnancy? Are we giving any retroviral? Megha?
For CMV, there is just one antiviral agent which has been tried in pregnancy, that is valacyclovir, and that too it is indicated when the CMV infection is in the first and the third trimester. So unless in the second trimester, then the fetus requires this monitoring, ultrasound monitoring, to see for oligohydramnios and microcephaly and any other stigmata of
Okay.
Same
So
dose.
basically, you are not giving antiviral
No,
for
no,
such patients.
no, ma'am.
So what about toxoplasma during pregnancy? Are you going to treat it? Are you not going to treat it? And what drug
Yeah,
are you?
toxoplasmosis during pregnancy, if it is confirmed. So we have a guideline which suggests the 18 weeks. Before 18 weeks, we have to give pyramycin, and the dose is around 1 gram 3 times a day, and then continue till the whole of the pregnancy. But after 18 weeks, if by amniocentesis it has been confirmed by a PCR test, then you should resort to pyrimethamine, sulfadizine, and folinic acid combination, which is better drug for toxoplasmosis, but should not be given before 18 weeks because it crosses the placenta in the first part. So after 18 weeks, you can give a better combination of drugs, that is pyrimethamine, sulfadizine, and folinic acid. So this is the guidelines, standard guidelines, which suggest the treatment of toxoplasmosis if diagnosed and confirmed in tests during pregnancy.
Okay. Now a girl is 6 weeks pregnant and she gets chickenpox. What drugs can you give to prevent congenital varicella? What is the medicine that you want to give? Can you give acyclovir?
Not enough time.
Yes, ma'am. We can give acyclovir.
Yes. So you would give 800 milligram 3 times a day and it would work. And if somebody has a confirmed Zika virus, how would that be managed?
That lady should actually avoid to go to endemic areas where the Zika is evident, and also she should avoid herself being bitten by a mosquito.
No, but she's already got it. Then what can you do? Basically nothing. You need to just examine and see if she has side effects, if the baby is affected. And if it is affected, then it is the parents' call to do what they want to do about it. If there is an exposure to methyl mercury, then what happens?
Like prenatally, we don't know what signs to look for on ultrasound, but basically it will be lead to neurodevelopment deficit. And the thing is, anything overconsumption, like wherever the source is, it should be avoided. It could be seafood or other things. Very
Now,
uncommon scenario.
okay. Now, one more question is that if the mother has hyperglycemia, then what effect do you see on the placenta? We know of the fetus and everything. What effects do we see on the placenta? Hyperglycemia.
Effect on fetal effects and placenta.
I'm not asking you fetal effects. I'm just asking you placental effects.
There may be placentomegaly.
Any fetal medicine person wants to add on to that? Polyhydramnios?
Yeah, definitely.
Polyhydramnios and yes,
placentomegaly, yes.
Now, maternal anemia is there. Does it affect pregnancy outcomes? It's maternal anemia.
Oops. Yes, sir. Maternal anemia can affect pregnancy outcomes because severe iron deficiency can also cause fetal growth restriction and preterm labor and can cause a hyperdynamic state in the mother. So cardiac issues can also be caused in the mother, which can transmit to the fetus. And also an effect can be low birth weight because of severe anemia.
The more important thing is the maternal mortality. Because the fetus usually survives because it is a parasite. A good placenta will take up everything from the mother, but it is the mother who doesn't survive her pregnancy.
And it's also, I mean, severe anemia is also associated with PPH of some effect during pregnancy. That could be one of the reasons, but yes.
So if phthalates and endocrine disruptors, you know, all these perfumes and everything, if the mother is exposed to that, then what happens? What happens to the fetus? These days, we
So,
are hearing so much about epigenetics. So what is happening to the fetus with exposure?
so phthalates, which are generally present in very polymers, PVC, water bottles through which water is consumed. So they cause DNA damage and especially affect the male fetus in causing hypospadiasis and cryptogenic testes. And in the females, yes, it can affect them by causing improper ovulation, but the effects of these would be seen later in the female as the ovulation and puberty sets in, but in the male, it can lead to hypospadiasis.
Okay. Okay. So you have to be alert even about the epigenetics and what you are consuming. That has to be advised. And can we see any of that in the placenta? Do we see any signs of all these endocrine disruptions by ultrasound? What about hypothyroidism, Divya? Should it be treated in pregnancy or not?
Yes,
And
ma'am.
are the medicines safe?
Yes, ma'am. Actually, untreated maternal hypothyroidism can result in low birth weight and neuropsychological impairment of the child. So we should replace this with levothyroxine, and the recommended dose is 1 to 2 microgram per kg per day. But we will start levothyroxine according to the TSH level, and we will monitor every 4 to 6 weeks till we achieve the normal level.
Okay. So now we come to the last two questions. If the mother is very obese, then what effect does it have on the placenta, pregnancy, and fetal outcome?
Maternal obesity is a high risk factor for many medical conditions in pregnancy. First of all, diabetes. If she is not pre-diabetic or diabetic before pregnancy, she can develop gestational diabetes. And in all probability, she would be a pre-diabetic or diabetic before pregnancy only if she's morbidly obese, right? And then later on, she can also develop preeclampsia because of her weight.
See, I'm not talking of that. I'm asking you a very specific question. What will be the effect on the placenta? Will you have a big placenta? Will you have a small placenta? If the mother is very obese, what effect on the placenta are you going to see?
Placenta will be large.
Anybody wants to differ on that? Usually, women who have a BMI between 22 to 25, the babies are good. And the women who are very obese have either very big babies or they have very small babies.
They have IUGR babies also. So those things are there. In that case, certainly the placenta will be like
You
small.
also have to watch for FGR in such
IUGR
women. So you also have to watch for FGR in these women, right? So both things have to be watched for. And if the mother is very stressed, does that have any effect on the fetal development?
Ma'am, the stress, to have some amount of stress in the pregnancy is very common, but taking it too chronic or very severe can lead to have an adverse effect on the perinatal outcome in form of low birth weight baby, FGR, aggravating of underlying if patient is a known case of preeclampsia. And we can manage it with the most important thing is she requires a help. She should ask for the help, the availability of the counseling, the family support.
She's a gynecologist. She's a senior resident. She cannot take off. And she's pregnant. What would you suggest to her?
Ma'am, I think the first is the priorities of family and then comes the work. Definitely, I feel.
So even for her, you would advise, yes, Suvarna, you want to say something?
Yeah, some social support from the colleagues, seniors, family persons, and she may need some counseling or meditation may help her, whatever time she gets, and bit lifestyle and dietary modification can help.
I would say support from domestic help also, which would relieve her work at home, and she will be really stress-free from that, right?
Yeah. Yes.
Yeah. So thank you so much. Yes, Ashwin?
Thank you,
I think
Dr.
women
Ma'am.
will
Thank
be
you.
privileged for domestic help nowadays.
Yeah.
It's very necessary to be stress-free for all of us.
Requesting everyone have your videos on. So I want to take a photo. And then one take-home message from each person before we end the session. Vinaya, we start from you.
Yeah, healthy lifestyle and diet would lead to a good baseline before starting pregnancy, and of course completing the vaccinations before pregnancy. So that will prevent a lot of infections as well.
No, don't forget our topic today is the physiology of the placenta.
So the vaccines, I would say, the rubella before pregnancy, achieving a pregnancy. So that would.
Dr. Manju?
Ma'am, I feel a very good history taking and a preconceptional counseling plays a very important role in having a healthy baby and a healthy mother.
Dr. Varun? Don't see Varun. Dr. Kulbhushan? Yeah, yes, Dr. Varun.
Yeah, sorry. Imaging of the placenta should be given as much importance as imaging of the fetus because it is also very important.
Yes. Starting from the first trimester.
Yes.
Yes. Dr. Kulbhushan? Dr. Suvarna?
Yes, ma'am. As we are obstetricians and fertility specialists, we all are focusing on the secondary prevention, that is giving treatment to our patient. I think we should go to move to primary prevention, vaccination before pregnancy, optimization of the obesity, hypertension, diabetes mellitus, and other conditions before we are planning the conception. We should focus more on primary prevention and preventive health care.
Thank you. Dr. Ashwin?
Our thing would be, I think, going through her documents again, her past history and everything to see what medication she's on and make sure she's on pregnancy safe medications rather than random medications.
So a detailed history taking covering everything is needed.
Yes.
Dr. Megha?
So a lot of emphasis is to be made on the preconceptional history of the patient and especially de-addiction to common agents like chewable tobacco, smoking tobacco, passive smoking, alcohol, which is getting very common in urban and semi-urban women. And then also having vaccination in place for these mothers and discouraging expectant and mothers to self-prescribe any form of medication without the consultation of the gynac due to the placental transfer of the various drugs.
Dr. Divya?
Ma'am, actually, this is an era of we are getting elderly primaries and the age of getting marriage going up. And we are getting more of medical disorders and many comorbidities too. So if we counsel them preconceptionally and we should modify these drugs and to the safer ones, then we could help these women and the fetuses.
Purvi?
Ma'am, I would like to second Dr. Adi sir's thing. It is a main organ. It is a very important organ. Let's not try to unsee it. Let's try to see it in every case.
Okay. So, Pratibha ma'am, K Shah sir, if you are still there.
Yeah, I'm very much with you.
Thank you,
Asha,
sir. Yes, sir. Your
very
last
well
comment.
conducted. Yeah, very well conducted panel. You had very distinguished panelists who did the job beautifully. I just want to add one thing, that when you were talking about trigger for late onset FGR delivery, I think it is CPR, cephalo-placental ratio. If the CPR is less than 1, you deliver the baby. Because in late FGR, you will have umbilical artery may show you normal waveform. But if you see the middle cerebral artery, and if it shows you abundant blood flow, then you know that that is not good in late FGR. And when the ratio, that is the umbilical artery ratio divided by middle cerebral artery ratio, if it is less than 1 in late FGR, that is an indication for delivery.
Okay. Thank you, sir. Thank you.
Yes.
Thank you and all the best again.
Thank you, sir. Thank you so much. Thank you.
I'll take your
all.
leave.
Thank you, sir. Thank you. Thank you for
Yeah.
being here so long. So,
Oh, yeah.
thank you so much, my dear panelists. You've really made a very great contribution to this program. I hope you enjoyed it. And next week, we are going to look at the cervix through the colposcope, through the microhysteroscope, and also through the ultrasound, normal and abnormal. So I hope you will enjoy that as well. Welcoming you to the next Searchlight Wednesday, 31st July. See you soon. Thank you. Thank you so much for being here.
Thank you.
I'm
Thank
so
you, ma'am.
grateful
Thank you,
to
ma'am. Thank you so
Aditya
much.
and all our guests, all our viewers, and all my panelists, Purvi, for getting this program together. Thank you, Ashwin,
Thank you,
Dr.
ma'am, for the opportunity.
Manjunath, Dr. Varun,
Thank you so much, ma'am.
Megha, Subarna,
Thank you, ma'am.
Thank you so much, ma'am.
Divya, Purvi,
Thank you.
Dr. Kulbhushan. I'm so very grateful. Thank you.
Thank you.
Thank you.